Do you have back pain? Have you had an X-ray or MRI? Maybe you haven't, but you think you should have one because you are having back pain. For decades now, medical doctors, physical therapists, researchers, and media outlets have been outcrying that MRIs are overused. Let's take a look at some quotes and headlines. This one from 2013, MRI for lower back problems, deemed overused. New York Times, 1994, the boom in MRIs, concerns grow on costs and overuse. This one from the Journal of the American Medical Association, in 2013, overuse of magnetic resonance imaging, MRI. Finally, from the American Academy of Family Physicians, imaging for low back. Unless something serious like a spine infection or what we call progressive neurologic deficits are happening, imaging shouldn't be done in the first 6 weeks. Imaging doesn't help you improve, and it can add thousands of dollars in unnecessary medical costs for you. Studies like these raise a lot of questions. It is natural to think that more information is better, or the imaging could help direct treatment, right? Well, not quite. Let's discuss what imaging does for treatment. MRIs are an amazing invention that has helped aspects of healthcare tremendously since it started being used in the 1980s. However, what this chart shows is that when people weren't being MRI'd as often, they weren't getting surgery, opioids, or injections as often. Let me repeat that. This chart illustrates that when a population has fewer MRIs, they have fewer surgeries, opioids prescribed, or injections performed. In other words, people with the same symptoms who didn't need surgery, opioids, or injections before now receive them. An increase in imaging by MRIs correlates with other more invasive and dangerous procedures and medications. Why is this? MRIs seem to encourage patients and healthcare providers to feel the need for interventions that have higher chances of negative outcomes for the patient. Sometimes injections, surgery, and even opioids are appropriate. However, what these graphs show us is that your chance of having a more dangerous intervention increases just by having an MRI. Each person who is having an MRI must be able to answer for themselves. What will be done after I have an MRI? You may think, well, that depends on what they find. That seems logical. But what we've seen is that it does not play out logically. If a more dangerous intervention wasn't considered prior to having imaging, then it probably shouldn't be considered after having imaging. The problem is that having imaging changes the course of treatment to a more dangerous path. I like to say the beauty of MRI is that they see so much. However, its beauty is also its dark side. Its advantage is its disadvantage. There are a plethora of spurious or incidental findings when viewing MRIs. They may not seem spurious, but they often are. They're commonly called wrinkles on the inside, meaning they may not look good, but they're harmless. Unless you are considering surgery or an epidural steroid injection, it is very rare that an MRI is indicated. Thus, your imaging very likely will have incidental findings, but these findings can lead to more invasive, dangerous interventions. This is why it's recommended to wait for 6 weeks until even considering imaging. This is why you need to ask yourself before having an MRI, what will be done after I have an MRI? If you've already had imaging, then it's recommended to really ponder if you've changed your treatment plan because of the MRI. If you have changed, then maybe you should reconsider your treatment plan. A lot of the headlines were for MRI, but as the American Academy of Family Physicians paper that we already discussed indicated, any imaging in the first 6 weeks typically shouldn't occur. Here's a great story about how having an image may be harmful if done and not indicated. Jerome Groteman is a respected physician and excellent writer. He tells a story of when he thought his wrist may be broken, so he got a bone scan, which is appropriate. His friend, the orthopedic surgeon, said that before they deal with the wrist, They need to investigate the spots on his ribs that looked like metastatic cancer. That night, he developed chest pain, intense chest pain. And even when x-rays taken the next day showed he actually didn't have cancer in his ribs, it took 2 weeks for pain and worry to subside. Let's say that, again, Dr. Grootman had no pain in his chest. An image showed he had cancer. He started having intense pain just due to thinking he had cancer. Even when he found out he didn't, it took 2 weeks for the pain to subside. This represents how imaging findings can increase our pain. Even a medical doctor who obviously knows new information shouldn't give him pain, it still did. In Dr. Grootman's case, it gave him pain that wasn't there before. Thus, it can happen to anyone. Here's a medical doctor who knew better, and it still took 2 weeks for him to feel better. If you get an image in an area you're already having pain, then anything found in the image can increase your pain, even if it's a wrinkle on the inside. Remember, wrinkles on the inside are findings that, like wrinkles, may not look good, but are harmless. Let's now talk about what imaging is relevant to pain. Early 2020, some super smart physician researchers published an article titled Significance of the Association Between Disc Degeneration Changes on Imaging and Low Back Pain. You're welcome to read the 13-page detailed article, but I'll summarize some of the points here for you. You don't need to understand all the terms, but it's nice to know in case you've had imaging or you're thinking about having imaging to know what it will show that could be relevant for your pain. People with modic type 1 and type 3 changes normally have pain. People with disc extrusion and sequestration, which are the most severe herniations, normally have back pain. Multiple levels of disc degeneration correlates with low back pain. For instance, if someone has disc degeneration at L4 and L5 and L5-1, then there is a higher likelihood of low back pain than if disc degeneration is just found at one level. Those are the most important 3 things that showed an impact on pain. I'll repeat them. Modic type 1 and type 3 changes, disc extrusion and sequestration, and multiple levels of disc degeneration. However, it is still not a cause and effect relationship, meaning there are other factors. For instance, it does seem that as people age, these findings aren't as important because they are normal changes. Whereas if they happen at a younger age, they aren't as normal, so there is a higher correlation with pain. Basically, if you have wrinkles on your skin, it's normal to have wrinkles on the inside. However, it is still not a cause and effect relationship. Take a look at this table from another review that looked at more than just the disc, but they only looked at studies with people who did not have low back pain. I tell my patients, while some of your imaging findings may be related to your pain, my goal is to make you one of these people that have these same problems on imaging, but no pain. This is an example conversation. You are 62. Your imaging shows disc degeneration. If you take 10 of your friends who do not have low back pain, 8 or 9 of them will have the same finding on imaging. For whatever finding my patients have, there is at least a certain percentage of the population that does not have low back pain, that does have their imaging findings. I tell them my goal is to find the factors they can control so they can be one of the people in the chart without pain. Let's look at a couple of examples of how this plays out in real life. Take John and Fred. Neither of them have low back pain, and neither of them have had any imaging of their low back. John has 2 levels of disc degeneration, though he doesn't know about. We do because this is a hypothetical situation. Fred does not have any disc degeneration. They end up having to work night shifts for a week, and so it really throws off their sleep schedule. Fred is quite tired, but that's about it. John is also quite tired, but his back starts to hurt. He gets an MRI and finds the 2 levels of disc degeneration. What is the cause of his pain? Before having his sleep totally thrown off, he had no pain, even though he already had the 2 levels of disc degeneration. Is it the multi-level disc degeneration or the lack of sleep that's causing his pain? The answer is yes. Pain is always multifactorial. In this simplified example, we have only 2 factors, and one of them can change: sleep. improving sleep for John is how we will get him back to being one of the people with disc degeneration that doesn't have pain. Did he need an MRI for that? Let's look at another example. Jane and Sally are friends. They both have disc bulges, and they exercise together. We know exercise is very important for keeping pain away. Tragically, Jane has a death in the family, and with the stress and the busyness of dealing with everything, she had to stop exercising for a while. Once she can focus on herself again, she goes to her doctor because she has back pain. She is told it is probably stress-related and to start exercising again. She tries doing the same routine she used to, but her back pain increases. She gets an MRI and it reveals her disc bulges. She now believes it is the exercise that must be hurting her discs, so she doesn't want to do that anymore. Let's take the data that we've looked at and see if Jane's assumptions are correct. She likely had the disc bulges prior to the tragic events in her life, because a sizable percentage of people her age do. Remember, Sally has disc bulges even though she doesn't know it, and she's continued to exercise without them worsening or aggravating her. Jane was doing better when she was exercising. Exercise will help her again, but she needs two things. First, the knowledge that exercise won't damage her back or discs. If she mistakenly believes that every time she feels a twinge or soreness that she's done damage, the pain will only increase. Second, she needs to grade back into her routine. That means she can't just start where she was. She needs to start at a lower intensity and volume, and realize that there will be some increased soreness and even pain as she returns to her previous routine. Knowledge will help her pain. Let's summarize what we've discussed in this video. There is concern in the media and in the scientific literature that imaging in general, and MRIs specifically, are overutilized. However, it can be hard to understand why having more information could ever be a bad thing. We then discussed Jerome Groteman's story where he didn't have any pain, but an image gave him pain. He is a doctor and this occurred. How will it be for most people who have an image taken because they are in pain and then see their image? It increases the pain they already have and more often leads to more invasive interventions. We then discussed some of the imaging findings are relevant to pain, but unless surgery or an injection are indicated, then imaging is probably not necessary, even if it is able to find something that is relevant with your pain. This is because there are many people with the same findings without pain. We need to focus on what we can control. Sleep and exercise are two examples in this video, but your healthcare provider can team up with you to determine what things you can control that will help you the most. Remember, MRIs show a lot. That's the beauty and the dark side of them. Some of it is meaningful, and some of it is just wrinkles on the inside. Wrinkles may not look good, but the findings are harmless. Unless you are considering surgery or an injection, you'll have less pain if you don't see it. Teaming up with your healthcare provider can help you become one of the people that doesn't have low back pain.